Welcome to Altoida at the Intersection. We are entering a new era in neurodegenerative care. For the first time, we have therapies that have been shown to slow disease progression, blood biomarkers that can detect underlying pathology with high accuracy, and digital tools capable of measuring real-world cognitive function and far earlier than ever before. But here's the problem. The healthcare system was never built for what is coming next. We are asking a system designed for yesterday's volumes to manage perhaps the largest ever diagnostic and treatment shift in neurology. Millions of people are already living with undiagnosed mild cognitive impairment, or MCI as it is known, and many more will soon become eligible for testing and treatment. This is fundamentally a numbers and outcomes problem. The standard of care for cognitive assessment was never designed to operate at this volume, particularly at the earliest stages of impairment where intervention matters most. Without cognitive assessment that is both accurate and able to fit into clinical workflows, early detection will not scale. Even the best therapies will fail to reach the people who could benefit from them the most. So this is no longer a failure of science, it's really a failure of infrastructure. Blood biomarkers can now approach imaging-level diagnostic accuracy, yet frontline and specialist care remains overburdened. Neurology access is constrained with very long and growing waiting times, often 9 to 12 months or more. And most clinics lack the workflows, the time, and the tools to assess cognition early and at scale. The result is often delayed diagnosis, it's missed opportunity, and patients showing up sicker at a stage where they're more costly to care for, precisely when intervention could have mattered most. Today's conversation is about that gap. We've brought together leaders from health systems, pharma, cognitive and science, and diagnostics to examine what has to align if early detection and treatment of neurological conditions like Alzheimer's are going to work in the real world. Across pharma, diagnostics, healthcare providers, and patients, these four pillars must move together. Because this problem is solvable, but only if our tools and our systems evolve with the science. Before I begin, I want to share a bit of context. This is the inaugural episode of Altoida at the Intersection, a podcast series where we intend to bring together leaders across healthcare, science, and technology to examine the real-world challenges shaping neurodegenerative disease detection and care. Our goal is to surface practical insights, highlight what it'll take across disciplines to deliver earlier detection, better outcomes, and more sustainable care for people living with neurological conditions and for the providers who are responsible for their care. I'm very grateful to our guests, each experts in their own right, for helping set the tone for what I hope to be many conversations at this intersection. All right, let's move straight into the introductions. We've got Matt Anderson. Matt, you are the Chief Medical Information Officer at Honor Health, a large integrated health system in Arizona. Please introduce yourself and then share from your vantage point how you see the challenge in front of us.
Yeah, absolutely, Mark. Thank you for inviting me to this panel discussion. I'm really excited about this. So yeah, I'm Matt Anderson. I'm a physician. I'm a family physician, primary care physician in Arizona. Work for Honor Health, an integrated network, and currently work as Chief Medical Information Officer, focusing on the ambulatory side of the world, so primary care and outpatient specialty. And really, what I see is the continued need for neurologic care. Continued need for patients and their family members, especially, to have some understanding, to be able to get the answers that they need. Oftentimes what happens when people start to have concerns about memory or dementia, they're really navigating it themselves from beginning to end. The patients are navigating it themselves. Family members especially are navigating themselves. And we're really trying to fit in a more population health, a more community-based approach to what should be neurologic care into sort of the same sort of system we've had since the 90s, right? It's overburdened PCPs on quota systems, trying to get through the treadmill of the day, and really fewer and fewer neurologists and specialists who are able to do the appropriate diagnosis for us, be able to start treatment at an appropriate period of time. So, really, we're thinking about how difficult that is for our patients, for their families, and how we can be better as a healthcare system.
Wow, well said. Well, I expect that we're going to learn some gems from you today, from real world experience, and look forward to all that you bring. Next up, Brian Hansen. Brian, you have spent years shaping the next generation of neurodegenerative therapeutics. Share a bit about your background and experience.
Thanks so much, Mark, and thrilled to be here with all of you at this kind of inaugural podcast and event. As you said, my background sits at the intersection of neuroscience, digital health, innovation, and clinical development. And I've spent the last decade of my career within pharma, partnering with technology partners, academic groups to really translate these emerging neuroscience and biomarker science into tools that actually work in trials and that ultimately help patients to learn more about the disease state and the efficacy of the compounds that we're investigating. A consistent theme in a lot of my work has been helping teams move from possibility into practice, whether that is kind of integrating these digital or biological signals, rethinking how we measure cognition and behavior, or designing kind of development strategies that are more patient-centric and operationally realistic. There's a lot that goes into this integration and these opportunities here, and I'm particularly motivated by how these new technologies can really unlock insights that we've historically missed, how we can improve a trial efficiency, how we can reduce patient and site burden, and ultimately help individuals work through their care journey and their care pathway with these new technologies. At this point, a big part of my role is in, helping organizations move from these exciting ideas, these external innovations, into real-world adoption, and to really kind of fundamentally change the way that we conduct clinical research now and in the future. And this has been increasingly even more relevant as we explore Alzheimer's disease and other neurological neurodegenerative diseases. So looking forward to speaking more and to getting into some of the exciting areas where disease-modifying therapies are playing a particular important role in this process.
That's great. Great background. And it strikes me that, and I'm sure we'll talk about this, the challenge that you've seen in trial design, trial execution, and getting treatments approved is not dissimilar from the challenge that Dr. Anderson sees in frontline healthcare. We got to find the right patients at the right time and put them on the right treatments. If we don't do that, we're going to continue to see trials take longer and ultimately not be successful.
Exactly.
Well, welcome. Dr. Emmanuel Streel, a colleague of mine. You have been on both sides, on the clinical side as well as pharma, and here now you are on the diagnostic side. Indeed, you've completed literally thousands of neuropsych evaluations throughout your career, seeing patients even up to this moment. Share your background and why real-time, accurate, and early detection of cognitive impairment is crucial from your clinical perspective.
Thank you, Mark, and thank you for the kind introduction. So my name is Emmanuel, and I'm the VP of Medical Affairs in Altoida, and I feel I have a foot in the work of Matt, and also one in the foot in Brian's world, because I had the chance to work from the clinical perspective, the pharma perspective, and that's the reason why I moved to Altoida, because we can put drug on the market, we can work with patients, but if you cannot, we're not able to precisely or early identify cognition, doesn't make any sense. So I start just doing my trainings in psychology, cognitive neuropsychology, and I train also, I've got a doctorate in biomedical science, but more importantly, I started doing this cognitive test in the early 90s. So it's been quite a while since I've been doing that. And the tests we were using at the time were the tests we are still using today, the mini-mental status examination, for example. And you have to understand, and Matt, you certainly understand that very well, we evaluate with the mini-mental status examination memory by saying, apple, penny, table. Can you repeat that? You have to imagine how far you must be advanced in the deterioration of your memory, not be able to remember apple, penny, table. So we use tests to screen cognitive deficit with a tool like that. So on the one hand, we have functional MRI, we've got tau PET. We are able to tell the amount of protein you accumulate on your brain, where you accumulate that in your brain in real time. And on the other side is apple, penny, table. So there is a huge gap. And it's extremely difficult to read the literature and to look at what is possible from a biological point of view, from a medical point of view, and what from a clinical point of view, from a cognitive point of view, we are able to do. So it's literally something that needs to evolve, and we need to bring certainly that clinical old-fashioned way to approach cognition in. We need to enter in the 21st century.
Thank you, Emmanuel. He reminds me that the mini mental state exam is as old as me, which doesn't sound like a first world 2026 diagnostic we should be utilizing to detect impairment at the earliest stages. So let's transition for a minute. Let's talk about the scale of the crisis. Dr. Anderson, when you translate national prevalence, and it is estimated that there are somewhere between 8 to 10 million people in the U.S. walking around with undiagnosed mild cognitive impairment, which Dr. Streel regularly reminds me should be considered anything but mild. It's the earliest form of the disease. But when you translate that prevalence to Arizona, you're easily talking about 200,000 to 300,000 people with undiagnosed MCI. If even a fraction of them showed up at your facilities tomorrow, what breaks first in your system?
Yeah, it's kind of fascinating when you think about, anything else that was that underdiagnosed, would have more conversation about it, would have more attachment to it. I also just think about the difficulty. We're just talking about the mini mental status exam. We were always trained to use apple, ball, penny, right, instead of apple, ball, table. So apple, ball, penny, and now there's not even going to be any more pennies. And so if you have such an old test that now we don't even have pennies anymore. It's so difficult. But the truth is, the first step for so many patients in the health system is through their primary care office. A lot of things go through urgent care, a lot of things go through the hospital and the ED. But for something like this, for something like cognitive impairments, you're really going to your PCP first. So the step one is the fact that we have a primary care shortage. It is difficult to get in and out of your primary care office. And a lot of people have different levels of comfort with taking and making those diagnoses. A lot of times people will feel good managing them, but they want to have a really good diagnosis. It's really difficult to get to that point. You can have some screening tests. You can do an MMSE in your office if you have the time, but oftentimes people don't have the time, and it's still a manual process where you're still trying to draw clocks and telling people to fold paper and put it on the floor. Like, it takes time, and that's just not really functional the way we need to work right now, where we're thinking about being more digital, when we're EMR focused and quality focused and data focused. That whole paper on the floor just doesn't work. And so, you're talking about overwhelming the system with an undiagnosed issue that's really quite sensitive. People don't like talking about it. They don't want to have that. You don't want your spouse or your loved one to have a cognitive impairment. So, you're sort of flooding that primary care front door with concerns, and there's not much else. There's not a whole lot of other options to go. You can go and try to do neuropsychiatric testing. That may be 9-12 month wait. You may be able to go to a neurologist. It may be 6, 9, 12 months, and then they may even go and do the same tests again. They may do the neuropsychiatric testing again. So you could really delay what you need to do. And so I think if you're talking about hundreds of thousands of people, say in Arizona, or like you mentioned, millions across the country, if they were to actively seek care right now, we would be in no way able to care for all of them and get them what they need with the current tools that we have.
Wow, that's really it's a stark reminder of despite AI, despite the latest in molecules, we still haven't advanced enough for baseline care. Brian, when you think about this from the pharma perspective, it's probably not that much different, but talk a little bit about this challenge that you see. I've seen data. I think there was a Nature publication saying that Alzheimer's may grow to 153 million people by 2050. We're seeing this is not just something that affects a few. This is no orphan disease. This is a significant impact. How does large global pharma think about this?
Again, it's top of mind. It's something that we can't can't get away from, and that we need to really bring front of mind. This isn't a future problem anymore. This is happening now, and this is happening across an aging and a younger population alike. So this idea that we now have disease modifying therapies, and that balance and that gap between burden and access is happening even earlier on in an individual's life is a really important problem. And this is a top concern for global pharma companies to really address. How do we get out in front of this? How do we come up with the right messaging and better inform a participant patient population, better inform caregivers and families, and really start to lead by example with better diagnostics and tools. I think that one point that I wanted to emphasize is that the fact that we have disease modifying therapies now that could potentially again show a real meaningful advance, like a 27 to 35% kind of slowing of cognitive decline over about a year and a half. That doesn't really matter as much anymore if you can't monitor that individual, if you can't measure or diagnose that patient. So the measurement is as important as the molecule itself these days. And I think that that's another critical piece that we need to, kind of collectively, address. And getting back more to this, global impact here, if we think about, different parts of the world and different patients and certain, kind of areas where that treatment gap, could exceed or meet almost 75%. We think about this a lot from like a US centric perspective, but, taking the global kind of, incidence, into consideration, there is a lot that we need to do to kind of build up that infrastructure to diagnose, monitor, and treat individuals. So how we do that, in a way that is meaningful, how we do that in a way that can actually, build and integrate this at a global, footprint, and it can scale and it can be still consistent. I think that these are all very important kind of areas that we're actively addressing and pursuing. But again, trying to think about how we do this meaningfully is the most important part.
And Brian, certainly, maybe I'll put you on the spot here. This is my conjecture. I struggle believing that 98% of Alzheimer's therapies over the last 20 years really didn't work. Talk about that just a little bit. Why do you think, if you agree with my hypothesis, why do you think we're getting those outcomes?
It goes back to the biomarkers, how we monitor this. So we are taking, even before some of the disease modifying, aspects, we were kind of collectively, assigning or diagnosing Alzheimer's without confirmed, blood biomarkers and with some limited imaging capabilities. What we've realized now is that even of those that are diagnosed with a cognitive impairment, the blood biomarkers, you could rule out 30% of those of having some other diagnosis. It could be vascular dementia. It could be a form of Lewy body. It could be a different aspect around Parkinson's or another aspect of FTD, ALS. Some early symptoms that are all going to be mixed together, and now we have tools to help with that. But that, I think, is one of the real driving factors of this kind of lumping of cognitive impairment and, this idea that we were using these very blunt tools to measure decline. And that was the gold standard. That has to change. That acceptance and that fundamental shift in how we diagnose and treat, that's what's changing. And hopefully that 98% doesn't continue, or we're in trouble.
Yeah. And certainly moving, I've spoken to a number of payers, national payers, who have referred to some of these treatments as exploratory, FDA approved treatments as exploratory. And, the subtext is, unlike cancer, when we put a patient on an aggressive chemo treatment, we can see the impact, whether it's having or not, and then we move to the next line of treatment. Amyloid beta removal isn't equivalent to cognitive function return, and so these tests, these assessment tools need to not only identify early, but as you mentioned, be able to longitudinally track. So payers will take these treatments more seriously, so they know whether they're working within their populations or not. Mm-hmm. Let's pivot a little bit to the clinical side. So Emmanuel, there's publications out there that talk about PCP accuracy in diagnosing versus specialists, and then the introduction of these new blood biomarkers showing dramatically better capabilities. But the reality is many patients today are diagnosed too late in order to benefit the most from some of these therapies. From a clinical practitioner perspective, what is the scale of the problem?
Well, the scale is massive. First of all, you need to understand that Alzheimer is one step, and before that we consider this mild cognitive impairment, and before that you start to have anomalies way before. So you might have a mild cognitive impairment, very early mild cognitive impairment, or you have a mild cognitive impairment which is pretty much the same as an early Alzheimer. So, and Matt, you will certainly agree with that. When you have a patient with Alzheimer, with effectively early Alzheimer, it's not that complicated to diagnose. You see it, you ask the carer, the problem are really obvious. And actually the test will capture that, apple penny table, you really will advance, you can't repeat that. The point is to capturing that very early on in the mild cognitive impairment. If you look at the literature, about only 8% of people are diagnosed with MCI. So we're missing in the US 92% of people with MCI, and these people are much more early on the window. These are the people who would benefit the most for any available treatment. We don't have many treatment. But as we're going to have more treatment, these people could benefit the most. MCI is on the indication for the drug available. So this is really a very interesting situation that many patients are actually diagnosed way too late to benefit from any therapy. Even without talking therapy, we could consider about lifestyle change, about using hearing aid and see how it could impact, and then consider treatment. We arrive way too late for that. So that is a massive problem that rejoins exactly what Brian was saying as we could have way more drug, we could have just way more way to intervene. And now we've got blood biomarker, and there is a paper that you mentioned, Mark. We can improve. We can improve, digital technology to capture. We can bring blood biomarker and digital technology together to improve and capture early on that pathway into MCI. And I think this is important to realize that.
That's a great segue. Let's talk for a minute about modern assessment combined with digital biomarkers and how we can use these tools to assess cognitive function. There seems to be a consensus trying to form on what is clinically acceptable from a digital cognitive assessment perspective. What does it look like? What are the validations that need to be completed? What is the sensitivity to MCI and the intended use in primary care? But I think that this is at least notionally telling us that digital is moving from a perch of being experimental to something that practitioners are actually starting to take seriously. I think it further highlights that, even though the USPSTF doesn't have guidance on this type of testing, standards need to exist. And maybe all of that is in support of the fact that experts know that health systems likely aren't just going to adopt anything. They're going to want to see a standardization and a clinically relevant platform. So, Emmanuel, let's talk about the current standard of care. This is something that you have spent your career in. And in particular, as you're highlighting that, I know that you recently had mentioned that there's some data showing modern cognitive assessment capability versus traditional MMSE. Modern seeing disease, MMSE seeing normal, healthy activity. Talk a little bit about the current standard of care.
Well, first of all, if you take, for example, Alzheimer and the new guideline that we have, you see that we consider blood biomarker and cognition or you evolve. And you see like a diagonal. The more your blood biomarker are increasing, the more your cognition is deteriorating. That's a classical, very rare though. The point is above that curve, you've got the people who have who deteriorate faster. They usually have co-pathology. But the bulk of that is below that line. These are people with a high cognitive reserve. They are people who are very highly educated, they stay sharp, and they compensate. So these people have a problem. If you look at an MRI, you might see a structural damage. If you take look at the tau protein, amyloid protein, you will see an anomaly. But if you just do a test, you won't see it. So it's literally this is the problematic person. This is the problematic population. Well, they kind of hide. So when we had pen and paper, and I work with that. And the next generation is that we digitalize that. It's a bit much more easy to use. You can use it on a tablet. You can use it on your computer. But the problem is, we try to test memory, Apple Penny Table. We try to test this and this and that. Now, the new generation is not trying to address memory, attention. We're collecting data. We ask people to do tasks, and especially capturing tasks. And it's very important from a clinical point of view. You want to see how does this cognitive function impact on your activity of daily living. So we want to capture data in a multimodal way, not memory, not attention, but where did I put my key? I entered this room and what I was doing here. So all of these things. So now we're moving to pen and paper, digitalized version, and to something which is working with data. And these data are associated with cognitive domain and cognitive subdomain. And we have a much more clear and granular vision of the cognitive architecture. And the future of that is because of data and because blood biomarker is data, we can combine that. We can use technology like machine learning. We can have an algorithm that can tell you, yes, according to the data, according to your data, it looks like you've got a mild cognitive impairment, and it looks like your amount of protein is very high. And you can do that in a very short amount of time with a high level of accuracy. So it's literally how we try to move forward. But one of the questions is much more around math expertise. How can we use these tools to move forward and reduce the burden? Because you have a lot of people knocking at the door.
Yeah. Well, and I think that's a good intro for you, Dr. Anderson. As you at a large healthcare system think about these modern tools, combination of digital biomarkers and blood-based biomarkers, how do you guys think about that?
I mean, I really liked, Manuel, when you were talking about kind of going from, pen and paper to digital to machine learning. There are other parallel processes that we see. I think about blood sugar, right? How long ago was it that everyone had like the checkbook calendar where they put their blood sugar on? I can't tell you how many times someone just handed me one of those calendars. It was just full of blood sugar results. But now we're going to more digital things. You can track it in your health kit on your iPhone. You can do continuous glucose monitoring. You can get algorithms that look at that, and you can look at it all the time. And so I think that's a really great model for what we could see for any disease process, and to be able to go from very very old school pen and paper to something much more actionable and real time. And when it comes to cognitive impairments, we're still at pen and paper. I think most systems are still at pen and paper because it's difficult. It's hard. It's hard to digitize. There's not that space inside the clinic sometimes to get that done. And I mean space physically, and I mean space temporally as well. There's just not that. There's not that ability to get that stuff done. So I mean, I really do think that having that trajectory is is what people are looking for. I just don't think people have seen it yet. And it's not always top of mind. I think we still don't even understand as a system what our risks are, how many people are out there undiagnosed. I don't know that's top of mind. It's also, when you think about some of the value-based care things, it's one of those that affects everything that we talk about, but we don't ever talk about that specifically, because that cognitive impairment is going to affect how you take care of yourself, the kind of exercise that you get. Are you taking your medications regularly? Are we even prescribing you the right medications? Just recently, there was an article about how many people have cognitive impairment and are prescribed medications that make that worse. We're doing that for people that we know have that diagnosis. What about these people who don't have that diagnosis? We could be prescribing things that are hindering their ability to stay functional, and we're doing that earlier than what we should. So I think that part of it is just knowing that there are options. Knowing that we can make an impact, knowing that there are tests that we can make earlier diagnosis and better diagnosis in the right space. And knowing that there are treatment options moving forward if we can find those right patients. We find those right patients, we get them the right tests at the right time, we get them the right medication, they have better outcomes.
And you had mentioned in a conversation we had recently, it's not like this approach for digital biomarker platform that can assess cognitive function is the first time technology has been used. You had mentioned a good analog for this, kind of paving the way, is what was done in diabetic retinopathy, where it was specialist only, and then it transitioned. How do you see that analog?
Absolutely. Again, you're thinking about tests that patients may not want to do. We know that every diabetic should have a yearly retinal screening. You need to be able to check those things. You need to be able to make sure that the number one cause of non-traumatic blindness in the country, that we're checking for that. But it's difficult. It's an extra step. You have to go from your PCP's office to another office. You're having extra copays. You're doing a lot of that extra work. And so traditionally, we do really poorly at that. Most healthcare systems, most physicians are not as good. Some are really good, but in general, we weren't that great. And, what we started doing is taking that diagnostic, that screening, and pushing it down from a specialty office into the primary care office with digital tools, right? So we have digital cameras now that you can use in the office, and they take pictures of your retina. And, sometimes you're uploading it and you're having someone look at it and make a diagnosis right there. Sometimes you're even using AI now to make immediate diagnoses to say, is retinopathy there or is retinopathy not there? And that's really what we're asking in that space. And what it does is it allows the patient to feel comfortable. You're like, oh, I'm getting this done as part of my routine. I'm going to go back and do that with my PCP every year. It's eliminating people from the referral queue that don't need to go. Right? They have good eyes. They don't have anything. You're taking that group of people who don't need higher level of care, and you're keeping them at the right level of care. So you're not escalating that. You're not increasing costs. And then you're having a different conversation with your patient when it is abnormal. You're not saying, go to this specialist, pay the copay, take time off from work because we want to screen you for something that may or may not be there. Now it's that conversation of, you have something that I found that is abnormal and I am worried about it. And so I think you need to go and get this, or we need to do this next step. And we've been able to really make a difference for our patients, for the health system in general, to be able to move that technology down one level from a specialty world into the primary care world, and really cause very, very good results for our patients. The patients who don't need anything and the patients that do need something.
Wow. I mean, we could spend an entire pod just talking about that alone. Hopefully we'll be able to double back. Really, really helpful. Brian, modern assessment, digital biomarkers, can work upstream, can help pharma upstream. What excites you about that, and how are you thinking about the potential impact for accelerating drug discovery?
Well, no, again, just building on what Matt was saying, I think that, what excites me really is about the intersection and balance between at-home testing and in-clinic testing, being able to take things that we have traditionally done, at sites, things that are, require that specialist, that burden, and to kind of figure out ways at which we can now bring them into, more of a remote hybrid kind of capability as we investigate and interrogate the compounds and molecules that we're looking at. This gives patients a sense of autonomy, a sense of ownership over their own healthcare. And it also allows us to pick up really sensitive changes in terms of, behavior where they don't have, let's say, that kind of that classic white coat syndrome. They haven't necessarily studied for the Apple penny table test as they're all putting on kind of their best behavior and really performing at their peak. We now get to pick up on those subtle changes that are happening, in the home, that happen at that frequency that is more consistent to, daily activity. And once we're able to take advantage of that kind of episodic testing and increase that frequency, the opportunity that also excites me is then being able to then layer on other passive measurements as well. Being able to combine both active assessment with passive, thinking about, kind of continuous glucose, thinking about aspects of activity, sleep, being able to have that now as a second kind of, additional context or, aspect around their behavior. In addition to that, more frequent cognitive testing is a really kind of, 1 + 1 = 3 type of approach as we think about the patient more completely.
No, it's hugely needed. And I just am constantly reminded at the parallels at the front end during drug development as they are in primary care. And it's interesting. It reminds me, there was a publication a number of years ago, I think it was the Society of Actuaries, they had done an analysis. And in the US, they defined 20 US states as dementia neurology deserts. And so this world where not only are you dealing with people that don't get access, can't get access, but even if they can, if you're talking about a big population in states where access to specialists is 4 or 5 hours away, even that accessibility cuts against it. It cuts against getting people into clinical trials. It cuts against getting people into clinical practice.
Well, just to build on that, as we were saying, even with disease modifying therapies, you now are looking at a patient population that could be, like a decade and a half younger than where we have traditionally treated and diagnosed individuals. So now you play into the factor of, they have, responsibilities with work and family, other caregiving responsibilities. Driving to a site that's 4 to 5 hours away is just not feasible.
No, Alzheimer's is not your grandparent's disease. This is something that's showing up earlier and earlier. And maybe someone 15 years younger than us knows what an analog or a digital an analog clock looks like, but kids growing up in high school today will have no context for what an analog clock looks like. So we've talked about the scale of the problem. We've talked about how diagnostics and new modern digital tools are evolving. But the harder question kind of underneath all of this is, even if we have better tools, can the healthcare system actually absorb what's coming? When I think about this, I think about systems missing early detection. The cost isn't just the delay. The patients show up later, they're sicker, and those sicker patients are more expensive to care for. We need to find them early when intervention would have mattered the most and potentially substantially fewer costs. As Dr. Anderson had mentioned earlier, a rapid no, you're not impaired is valuable because it does stop the referral networks from getting overtaxed. National clinician groups and policy leaders have been very, very clear on this point. Alzheimer's and MCI are profoundly underdiagnosed. And it's not because clinicians don't care, it's quite contrary. But primary care simply isn't set up. We've heard on this very podcast, they're not set up with the time and the workflows, reimbursement, or infrastructure to handle early cognitive assessment at scale. There's been multiple publications from frontline healthcare clinicians consistently highlighting non-billable work, fragmented pathways, misaligned incentives as some of these core barriers. So let's talk about the reality inside health systems. what actually breaks first when you introduce blood biomarkers, disease-modifying therapies, and some of these earlier digital detection capabilities into today's workflows? And what would we need to do to change in order for this to work in the real world? So, Matt, I'm looking right at you. From your vantage point as CMIO of a large health system, where do you see the biggest friction points when theory meets operations?
Yeah. And ultimately, it all comes down to change management, specifically with clinicians. I always remember one specific physician I was working with once who said, all change is bad, even good change, because it's just one of those things. You get used to it. It's part of your flow. This is what we've done. We have been trained this way. And it's really hard to overcome some of those hurdles. The biggest issues, I think, is you have to have the patient and the clinician on the same page. You have to be able to have that good communication between the two of them. And what they both need is education. You need to be able to say, we have these tests. We have these new biomarker tests. We have these new digital tools to help monitor those things. We're going to use those together. We're going to make sure that you have a great diagnosis, and we're going to do it right here in this office. And the patient needs to know, this is something that I want. I want biomarkers. I want digital therapeutics. I want digital diagnostics. I want to be able to track these things at home. Without those two things, you're really not going to get much buy-in anywhere else. It's like continuous glucose monitors. I've used them. I still get a little bit nervous every time I have to click that button and that big needle goes into my arm. But lots of people love this. They love getting their data. They love knowing what's going on. And I think we're moving away, farther and farther away from that sort of patriarchal healthcare system, patriarchal clinician system, where it's like, you're going to do this, you're not going to ask why, and that's the way it is. We need to be able to be much more open, much more collaborative with our patients. So I think it starts there, in my opinion. It starts there with those discussions that the clinician and the patient's family too, in this situation, want this. And then, even if we have all of those things, you have to have access to the tests. You have to be able to get reimbursed for the workflows, for those diagnostics, for that continuity of care. You really need to have systems in there so that you have some ROI. Because at the end of the day, we still have to keep the lights on. You still have to pay the rent. You still have to pay your staff. So you need to be able to have workflows that work for the clinicians, that work for the patients, and then make sure that you have in the background those reimbursement pathways. We talked about retinopathy a little while ago. When these cameras first came out, you had a lot of clinicians using them, and now it keeps moving down. So a lot of times our clinicians aren't even using retinopathy cameras. It's staff. Who are doing it. It's our clinical staff that are doing this. So it's not even the clinician themselves. So we have to be able to have everyone from the front office, so the people answering the phones, our staff being able to train to do some of these things, clinicians to interpret, and then, the right contracting, the right reimbursement pathways, the right rev cycle tools to make sure that we're tracking that over time and that we're getting reimbursed for the accurate amount of cognitive work that we're doing.
When you think about a platform that could rapidly and early identify cognitive impairment, obviously there's a fee-for-service component to that, but you're part of a large health system and you guys think well beyond fee-for-service. When you think about risk adjustment factors, when you think about your population and the comorbidities, what does that look like? In an aging population where you can identify comorbidities, you can identify MCI within a large population. What does that mean to an organization like yours?
In the old days, they used to say, if you didn't write it down, it didn't happen. Now it's, if you didn't submit a code, it didn't happen. So, you've got to be able to document the appropriate view of your patient that you're taking care of. That's so important for ACO work, value-based care work, to be able to have those right diagnostic codes ready to go. It can make a huge difference in what you're doing. So appropriate appropriate coding is really key, because ultimately you're going to spend the same amount of money on those patients. You're going to do the same thing for them, but to accurately code shows the world, or shows Medicare, shows the insurers, shows the payers how sick your patients are. And, whether they have mild cognitive impairment and you know it in your gut and you're treating them one way, or you have a real good quick diagnostic and you can say, based on this diagnostic, I know that this diagnosis code applies to this patient, and that adjusts your risk factor, and that adjusts your overall payment over time, and says, I'm taking care of, as a population as a whole, a sicker group of patients. That affects reimbursement. That affects a lot of different things down the road. So I think those are looking at this from a broader community-based approach, knowing that you have a convenient way to appropriately diagnose and to appropriately document is a huge opportunity for value-based care and at-risk contracts.
Yeah, that's amazing. I mean, we're seeing the rise in things like AI scribes to even help make workflow efficiency better for clinicians. Imagining a world where you can pull together packages to be able to drive reimbursement capture in a more seamless, streamlined fashion is probably significantly valuable. So even if we solve, go ahead. No, please go ahead.
I was just going to say, we were talking a little bit about diabetes. Diabetes is one of the huge chronic care conditions that, affects spend overall. You're kind of talking about diagnostics and biomarkers. The most common biomarker there is the hemoglobin A1C, right? Mm-hmm. We use that in combination with glucose monitoring. So you think about how we do continuous glucose monitoring, which is sort of that long-term in the patient space. It's sort of at there with them all the time. And you have the blood biomarker of the A1C. Those things kind of go together. If we had those type of tools working together for our primary care mild cognitive impairment patients, we would have a huge arsenal to move forward.
Yeah, absolutely. So let's pivot just for a minute here, and then we're going to jump into some rapid fire. I want to put you all on the spot and test your cognitive function. I'm teasing. I won't do that. But even if we solve the technology and the workflow challenges, there's another pillar that really determines whether any of this actually succeeds, and this is communication. We know from both clinician surveys and patient research that people living with cognitive decline, and this is a sad fact, can often normalize, minimize, or even avoid it altogether. It's like, hey, there hasn't been drugs for a long time. There haven't been treatments for a long time. It reminds me of a movie I used to watch. If I make believe I have it, then maybe I won't actually get it, kind of thing. Primary care physicians report uncertainty about how to raise these concerns. Patients hesitate bringing them up. And families often enter far later into the process than anyone would want. At the same time, there's growing confusion about what all these different tools mean. What's screening versus diagnosis? What's pathology versus function? Risk versus disease? Is the pathology equivalent to the disease? Do you need cognitive functional impairment and pathology? So in this part of the podcast, I want to focus on how we communicate responsibly. How do health systems talk about early cognitive change without creating fear? How do clinicians set expectations around new diagnostics and therapies? And how do we help patients and families understand what action looks like at each of these stages? So, I'll come back to you, Matt. When you think about adoption inside a health system, how much does clear communication and expectation setting matter for the leaders making these decisions?
I think it's critical. I think it's really critical, because what is important to the leaders, to the experts inside a health system, the quality, the safety people, the experts in their specific fields, that's what we focus on, and that's how we communicate out. Health systems have teams. We have population health navigators. We have care navigators. We have nurses and medical assistants, and we have entire marketing departments whose job it is to communicate those things out to patients. I think of things like breast cancer screening, colonoscopies, awareness months, prostate cancer awareness month, and those are things that people embrace quite a bit. People make it a fun event, and it's sort of weird. Before, many years ago, cancer wasn't a fun event. That was not something that you talked about. That was not something that was pop culture. Now kind of is, right? Everybody has bracelets, live strong. I guess that's a little bit different now, but that idea of that community, I think, is really important. And I think that's where health systems can come and break down some of that stigma. Hey, this happens. This happens. This is going to happen to you. This may happen to a loved one. This may happen to a friend or colleague. And we have tools to help find it earlier, and be as aggressive as possible. So I do think that there's a huge opportunity to lead in these systems.
Yeah, I agree. And it's interesting, if you are now watching, I actually saw this, the Hallmark Channel seems to play a lot during the holiday season in my house. We saw some of the large pharma companies having commercials for the new disease modifying treatments, and the way that they're describing it and talking about it, I think really does a good job at demystifying. It really brings those instrumental activities of daily living to the front. So, Emmanuel, I think that this is a good lead-in for you. I think we hear this a lot. Oh, well, there's a 3-minute screen. We took the clock drawing, we digitized it, or let's just do a quick screen. Let's talk a little bit about digital biomarkers being functional assessments, not simple screens, and maybe you can clarify some of the misconceptions.
Yeah, but I like to, first of all, I want to say that I really like, you mentioned glucose monitoring. People love to detect and monitor their glucose, and they do that earlier and earlier because they realize they have a control over it. So we have a control over cognition, providing we detect that very earlier. And a clinician like blood biomarker, they want to know how much protein you have on your brain. Is it, there is, pathology in your brain. People just want to know if they're going to remember the name of their children. And that is a very important point. And digital biomarker bring both together. Digital biomarker, the most advanced one can bring both. They can tell you, if there is an anomaly in your functional network, in the way you process information, and they can give you a lot of granularity. So you can have a problem with attention, and it's your attention that prevents you to succeed in memory, in flexibility task. But you can have an absolutely normal attention, and then your memory has got a serious problem. You've got you've got dissociation, a double dissociation. You can have a problem in memory, not in attention, and the opposite. So it's important that the most advanced can give you this granularity, and not only say, yes, that there is something abnormal, but help the clinician. How is your language? How is your memory? How is your attention? How is your executive function, the flexibility that I mentioned? And this is very important because this is not only saying you have a memory problem. This is you have an attention problem. What does that mean? We need something. This is meaningful for both the clinician and the patient. And at least the most advanced digital biomarker are bringing that. Something which is objective, which is scalable, because something can be a self-assessment, and that gives information to the clinician that can be used immediately, and for the patient that means something, that it helped understand. Because you say to a patient, your amount of phosphorylated tau is elevated in your brain, it doesn't mean a lot of things. It's important, it's crucial, but it doesn't mean anything. Saying that, well, last session your memory was kind of a bit below average, but now you're catching up. Whatever you're doing, it's helping you. And that information give hope, and give a clear insight to the clinician. And this is that type of thing that we're doing. And you can't have that with apple penny table or by drawing a clock. Let's be clear. So this is much more the 21st century, and this is where we should go.
Yeah. And, Brian, I want to come to you in just a second, but it does strike me that, 15, 20 years ago, I think the notion of having cancer detected in your body, well, it's still horrible. We've advanced so much that people can lean into it, and there's multiple opportunities for curative care. There's data out there that suggests of those 8 to 10 million people walking around with undiagnosed MCI in the US, potentially as many as 40% of those could have modifiable forms that if they knew about it with diet and exercise and various non-pharmacological things could potentially significantly slow or alter the trajectory. So we got to use language that's non-stigmatizing. There's a great organization that we are affiliated with. The website's notdemented.org, using language that destigmatizes, because people do worry about this, but they need to have hope because there are options for them, and platforms that accelerate pathological diagnosis, cognitive impairment diagnosis can only help in getting the right people into those right treatments. As you think about it from the pharma perspective, we've got to have better success in these treatments, which maybe means using different technologies as endpoints. But when you think about it from the perspective of communicating the value proposition of joining a clinical trial, accelerating drug discovery and development, how do you think about it from that perspective?
Just taking all of this conversation kind of collectively for pharma, the stakes have never been higher. The idea that we could potentially, stop the progression or slow the progression of Alzheimer's, really requires us to be able to thoughtfully communicate that process, how we arrive at that process to patients, how we identify them early, how we measure change accurately and consistently over time. There are so many potential ways at which we can go about that. And again, to build on some of the points that Matt was making, really trying to destigmatize this, embrace this, idea where, it's not the same diagnosis that it once was. We now have disease-modifying therapies on the market. Again, a decade ago, it was probably, sleep better, get some more exercise. But now we can, clearly remove, amyloid. There are companies working on, stopping the spread of tau. These are approaches that we will be taking, and that combination now gives patients some understanding that there's more than just lifestyle modification. While that is also important, that's something where maybe those, technologies around monitoring health and activity and cognition, can really start to play into patients wanting to learn more about their own health. The same way that you might have somebody who does not necessarily have diabetes or has, some sort of kind of, metabolic disease, monitoring their glucose, monitoring their, that approach of trying to learn more about your own health, to understand about, the disease or potential approaches that you might want to be able to kind of, get out in front of. That's an exciting opportunity for where some of these tools can play. And again, for work that, you and Altoida are doing, being able to have those tools that can be used in the clinic as well as at home, being able to provide that insight into how we diagnose and treat and how we, move molecules, within pharma, and then see that handoff into Matt's space. That's a really exciting opportunity.
Yeah,
and that these are not
well
just,
Well said. And, my blood pressure, my heart rate always seems to be higher when I go to the doctor. If we could monitor ourselves, the CGM concept is really the concept of the future for healthcare tracking and monitoring. All right. So listen, this has been a fabulous conversation. We've covered a lot of ground. To close, I want to look forward for just a moment. The direction of travel is clear here. We've got more disease modifying therapies on the horizon. We've got earlier diagnosis by pairing digital cognitive assessments with blood-based biomarkers. And frankly, there's growing pressure on frontline healthcare and specialty systems alike. The question isn't whether this is coming. I think that we've established it's coming. The question is whether health systems are prepared for it in a coordinated way. So I'd like to do a quick lightning round. What is one practical change, one priority, or one shift that you believe matters most if we want to move from where we are today to a system? When I say system, I mean pharma, I mean industry, and I mean healthcare providers that can actually deliver early, scalable, and equitable neurodegenerative care. Matt, you're on the hot seat. Let's start with you.
Yeah, I'm going to say that it's bringing the whole gamut to the frontline primary care clinicians, being able to know that you have the blood biomarkers, that you have the digital diagnostics, and that you have some potential even treatments that you can do frontline, and then you can refer and kind of keep early access, early treatment, and then referring only when needed.
Excellent. Brian, from a pharma perspective.
Disease-modifying therapies of tomorrow will only reach their true potential if the measurement and monitoring systems that they're paired with are patient-centric, scalable, and can be deployed globally. Having a transformative molecule is necessary, but it's not sufficient anymore.
Wow, powerful. Emmanuel.
Well, it's difficult after these two statements, very strong. One thing is all these old tests or legacy tests have been useful for a while. But I think if you think about the future and the standard of care, what it should be, I think it's undeniable. We need to work and bring biology and behavior together. So it's bringing blood biomarker and DCA, digital cognitive assessment, digital biomarker. In whatever order, we need to think, clinicians need to think about that. Do we start with blood biomarker, moving to cognitive assessment? Do we need to do the opposite? But these two powerful elements together bring immediate information to the clinician that helps to decide, oh, I'm worried. I need to do something. I need to prioritize that patient, and I want to do that type of test or that type of test, or I need to confirm that, or maybe exclude something and move in one direction. So for me, this is really where we going to.
So maybe in frontline healthcare, it's faster detection, it's quicker diagnosis, it's fewer handoffs, it's more satisfied patients, it's better outcomes for the patients and better economics for the providers. It sounds like a win-win. Well, this has been a really amazing podcast. As I close, I want to remind us, come back to the 4 pillars we've been talking about today with this great panel. First, pharma's got to continue to accelerate development of these effective disease-modifying therapies. Those advances are real and they matter, but their impacts, as Brian just said, depend on our ability to identify the right patients early and measure meaningful cognitive function change over time, which is essential. And it's where scalable digital cognitive assessment becomes kind of the pole position. Second, diagnostics must give us the capability to see disease earlier and more clearly. We've talked about at home, we've talked about easy to use, reliable, scalable digital cognitive platforms need to be paired with FDA cleared blood biomarkers. Biology tells us what's happening. Functional assessment tells us what it means for people's lives. Together, they enable earlier detection and more informed treatment decisions. The third pillar, healthcare providers and health systems must execute on these capabilities. That means driving adoption of approaches that actually fit into real clinical workflows and reimbursement and value-based care models. Without scalable infrastructure and aligned incentives, we're just not going to have the capacity to meet the demand. And even the best tools and therapies won't reach patients. And lastly, we need to do a better job educating people at the risks and those living with mild cognitive impairment. That means countering stigma and fear. It means normalizing the idea that early detection isn't a sentence, but it's an opportunity for action and hope. I do believe the problem is solvable if we align tools, systems, and communication. At Altoida, this is precisely the problem of our digital biomarker platform was built to address by delivering objective, scalable, real-world functional assessment that integrates into clinical workflows and complements biological testing. Our focus is on enabling earlier detection, better triage, and longitudinal monitoring that health systems and clinicians can actually use at scale. That's the work we're committed to and why conversations like today's matter. And before we wrap, I'd really like to thank my esteemed colleagues, Dr. Anderson, Dr. Hansen, Dr. Streel for their insights, for their experience and their candor. I feel like I'm the only one that's not a doctor here. I'm regretting that decision. This conversation reflects the kind of thoughtful cross-disciplinary collaboration that we're going to need if we're going to make real progress. And I'd like to thank you all for listening. Thank you very much.